Hello everyone. Today we are going to do a small lecture. It is on the choice of drug therapy in primary, which is also known as essential hypertension. So this is supposed to complement ICM. It is also supposed to be to complement the pharmacology lecture on antihypertensive. So there's going to be some repetitive stuff and some things you've already maybe seen in my pharmacology lecture, and then also maybe be seen in the ICM, but this is done just to help students hopefully kind of, again, connect the dots, make some connections as far as the approach to the patient and then the selection of, which antihypertensive, because you guys remember from my antihypertensive lecture, there's a ton of different drugs. So this will hopefully help you guys, get a good place to start. So first off, unfortunately, for the students, and when you're learning this, there is not a uniform agreement. So there is not a consensus among experts and among some of these different organizations that set up guidelines for antihypertensive treatment. So unfortunately, there's not just this one drug you can remember for every patient. It is going to be a very custom, tailored approach you're going to have to take to your patient. You have to take into consideration their other comorbidities. So do they have diabetes? Yes or no? Do they have depression? And then also other things too, like are they old, young, male, female? What's their genetic background? So unfortunately, there has not been a consensus on just, this is the one thing you give to everybody. It is something you're going to have to really kind of look at your patient and take in consideration their other diseases, etc. However, you can safely stick to these top three options. So thiazide type diuretics, the ACEs/ARBs, and calcium channel blockers. So those three are going to be your go-to for the majority of your patients and going to be a good place to start for most of your patients. And I mentioned this before, you can go ahead and, for this presentation, you can go ahead and classify the ACEs and ARBs and kind of think of them as being interchangeable. But for testing purposes and for my other presentation, please separate them out. Make sure you know which ones are ACE inhibitors and which ones are ARBs, or the so-called ARBs, the ARBs. And know that they are pretty much the same with the exception of some of their side effects. So please look at those, make sure you know how they differ in side effects. But you'll see this a lot in the literature where they will put ACE/ARB or ARB, and because they're pretty much interchangeable. But I don't want students in the past to be like, oh, they're the same thing, and they don't pay attention to the slight differences. But for this foundational knowledge you guys are getting this year, I want you guys to pay attention to those little details about how they're different. Having said that, so anyways, and then some of the older literature too will show the beta blockers being first line, and some of the older practitioners may do that. But just know too that more current guidelines, current recommendations, is that the beta blockers are rarely initial therapy, especially monotherapy, which is when you give something by itself. And so it's really going to take a specific patient, and so you're going to stick, like I said, stick to these top threes: thiazides, ACE/ARBs, calcium channel blockers. I mentioned this before in my slides for on antihypertensives, but first line, lifestyle modifications. And another thing too is patient education. You guys are going to be getting a class on that and be learning more about that. I just put it here for completeness sake. I won't be testing you guys explicitly on this stuff, but it's just in here, just FYI for my course, but it may be testable for other courses. I don't know exactly, so don't necessarily ignore this for every class, but for my class you can. Just read through that. Look through this again. We talked about this in my other presentation, so I won't spend too much time on this, but again, just it's the same table as my other slides. So the patient has failed with lifestyle modifications. You want to prescribe a medication for them. That's why they're there seeing you guys, right? Stick to guidelines when you're new practitioners would be my recommendation. And specifically, what is that? That's JNC 8, which I talked about, is the Joint National Committee. The other one I didn't mention before is the European Societies of Hypertension and Cardiology. So here's the abbreviation there. So you can go to either one, look at them. They're a little bit different. And like I said, some of the times the European practitioners prefer certain thiazides or the thiazide-like diuretics over hydrochlorothiazide. So there's a little bit of differences here and there, but for the most part, they're pretty consistent. and they're both credible. So you can go with either of them, and you can feel comfortable. Again, like I said, especially as a new practitioner, it's something. It's a nice guideline, a nice a framework for you to begin with. This is interesting slide too, and again, maybe repetitive from ICM, apologies, but it's you can go ahead and sometimes depending on the patient and the severity of their hypertension, and you'll notice the cutoffs here, you can forego the lifestyle modifications, and you don't have to necessarily wait to see if the lifestyle modification should be effective, and you can go ahead and just prescribe a medication right away. So take home point for this slide is that, depending on the severity of the patient, and again, going back to what I initially said, it's a custom approach you have to take with hypertension with patients. Most of your patients are going to be started with a monotherapy, which mono means one, right? So monotherapy versus a combination therapy. But this slide here is just highlighting the fact that, again, depending on the severity of the blood pressure and what stage hypertension they have, etc., you can initiate treatment with 2 drugs. Again, it's going to really depend on the patient, and you please be careful with it, because when you add additional drugs, you increase risk of adverse effects, right? And the big one that I highlighted for all the antihypertensives is hypotension. So you notice that it says that they're especially for elderly because of fall risk and then brittle bones, etc., and then also for diabetic patients. So those are 2 patient populations you might want to be a little more conservative with, even if they have higher blood pressure. Just be cautious of that, and be mindful of the other adverse effects I listed. So like I said, there's a method to my madness. I don't have you guys just memorize random stuff. I want you guys to know the adverse effects for these antihypertensive medications. And the big consistent one being hypotension, is because once you start, because a lot of your patients are going to need more than one medication. Monotherapy can work, and lifestyle modifications can work, but the unfortunate reality is you do see patients on a lot of different antihypertensive medications, or a combination rather, more than one. And so it's important to know if a person's on an ACE inhibitor and a beta blocker, what adverse effects you have to be concerned with. Are there going to be, or are there some that are going to be more pronounced or worse with them? So guaranteed with all of the antihypertensives, once you start combining them, you need to be more concerned with hypotension. So with one medication, you have to be concerned with hypotension, but then you start adding 2, 3, etc., and that increases the risk of hypotension. This is just also saying that, again, depending on your patient, going back to that customization thing, it's going to be kind of the theme here through this presentation, is that you may want to have a more aggressive goal depending on the patient. Here's some risk here, or some things that are listed here, read through those, but it's just basically, again, your goal may be different too, again, depending on your patient. This is repetitive from my other presentation, but I liked it a lot, and again, I want you guys to pay attention. I think it's a great table, but it's where you need to look at the comorbidities of a patient and see what else is going on with them. I talked about depression before as an example, and with beta blockers, but definitely pay attention to this slide. Put a star by it. It's good for testing purposes, but I want you guys to make sure that you know when there's a compelling indication to prescribe a certain class of medication. So if a person has angina pectoris, for example, having a calcium channel blocker or beta blocker on board is a compelling reason, because it benefits both diseases. It'll help with the angina pectoris, and it will help lower blood pressure, right? Same thing with the likely to have a favorable effect on symptoms in comorbid conditions. So if someone has hyperthyroidism, the beta blocker actually can help with the symptomology with that disease plus their hypertension. So maybe that may be your first line choice if a person has hyperthyroidism, which we'll talk about later in the year in our endocrine module. But so don't stress if you don't know too much about that now. Contraindications, again, I've been kind of hopefully hammering this point home. Look at those and pay attention to those. And then again, may have an adverse effect on comorbid conditions. So classic board style question: the patient comes in, they have gout and they have high blood pressure, right? So you'll notice here the diuretics actually can make their gout worse. They can maybe cause some hyperuricemia. You'll guys hopefully remember that from my slides in my other lecture. And then that'd be the reason why you shouldn't pick a diuretic, let's say. So anyway, so spend some time with this slide and try to and hopefully kind of make connections too with, like I was saying with the diuretics, think about the adverse effects of diuretics and then why that would be bad for gout. And again, like I said, with these modules, hopefully the goal is at the end of all three pharmacologies, you'll be able to connect the dots and make these connections. And that will hopefully help you be a better practitioner, right? All right, summary and recommendations. This is just saying that the different organizations of experts and stuff basically said that it's not just the choice of antihypertensive that is the most important thing, and it's more about blood pressure reduction. And so that's, again, kind of harking back to what I said initially, but just that it's not one drug solves a problem for everybody, and it is something you have to look at the individualized patient. Monotherapy. So depending on the patient, again, and their goal you have and how aggressive you want to be with them, and you see this a lot in the guidelines, etc. They recommend starting with a monotherapy. And you'll notice here that they are the three classes that we had talked about before, but you want to start with, and you notice too it says low dose thiazide diuretic. You typically, this is in general with a lot of antihypertensives, but definitely with the thiazides, they talk about starting low, go slow, and you'll hear that with other things in medicine too. But that you don't max them out on the diuretic right away. Again, that's related to the adverse effects, which hopefully you guys are studying and learning and everything. But you just expose the patient to more risk of adverse effects. Hypotension, of course, but then there's also those electrolyte abnormalities, right? You have to be thinking about with the thiazides. So with the lower doses, you typically have less of a chance of adverse effects. I mean, you can always have adverse effects, but again, that's part of the strategy there. The long-acting ACEs and ARBs, and then long-acting dihydropyridine calcium channel blocker. So just a quick note on that. Like I said, with classification of drugs, there's a lot of different ways to do it. But just please note the dihydropyridine calcium channel blockers are the ones that are examples of nifedipine, amlodipine, nicardipine is another one. And then the non-dihydropyridine calcium channel blockers, those are ones like verapamil and diltiazem. So those are the ones that would not be good choices for the initial monotherapy, right? And then the calcium channel blockers can be used for other things, whatever. So we're specifically talking about essential hypertension. And the reason I'm circling back or kind of coming to that point is sometimes in the past students they get their wires crossed, so to speak. It's, I thought calcium channel blockers were for heart failure, or I thought they're for angina or whatever, I thought they're for other things, but it's specifically we're talking about, hypertension, essential hypertension or primary hypertension. So the long-acting dihydropyridine. So, and again, just to be repetitive, that is, we're talking about nifedipine, amlodipine, nicardipine as some examples for monotherapy for hypertension. So this is also an interesting point here that I think you guys should kind of spend a little bit of time with. Make sure you read through the slide, understand it kind of top to bottom. But the take-home point here is that it's great to start with monotherapy, and it's great for people to be on less drugs, but then the reality of the situation is that people end up needing to be on other medications. And so because of that, they suggest starting with either an ACE or an ARB or a dihydropyridine calcium channel blocker, because that is a great combination for patients to be on. So the theory is, you start them on an ACE, and then if you need to add something, you go ahead and add a calcium channel blocker, because that's one of the best combinations you can use. And then for specific patients, ACEs and ARBs are better for the younger patients, and then the calcium channel blockers are more effective for elderly and then African American patients. So again, depending on your patient and who they are, again, you can kind of rationalize and start with one versus the other. So if you decide to start with the diuretic, there is more evidence, especially in Europe, coming out that the chlorthalidone and the indapamide are maybe better choices. And like I said, they're more popular overseas. But in the US, more clinicians have more experience with and are more comfortable with HCTZ, the hydrochlorothiazide. And so you see that being prescribed a lot more. But just note, as with all of the thiazide and thiazide-like diuretics, you still need to be concerned with hypokalemia. So that is something to star and make sure you are paying attention with as far as adverse effect goes. There are some potential limitations with the chlorthalidone, other than it just being that practitioners aren't familiar with it. And I'll let you guys read through this. And these are probably reasons too why I see more prescriptions for the hydrochlorothiazide than I do for the other thiazide-like diuretics. So this slide is just talking about how you can go from one monotherapy and then completely discontinue that drug and then go to another monotherapy. So you could start them on a diuretic, a thiazide, completely discontinue it, and then put them on an ACE inhibitor. So that is a potential strategy. But JNC8 actually recommends that you push the dose, meaning you go up to maximum dose and you try to, max out the dose before discontinuing it and switching to another monotherapy. Combination therapy. So again, I mentioned that the ACE or ARB plus a long-acting dihydropyridine calcium channel blocker there's been a lot of great evidence showing that is a very good combination for lowering blood pressure. And there's this big trial called the ACCOMPLISH trial, which the ACCOMPLISH stands for something. You guys can look it up. Don't, if you have extra time, but don't stress about it. But it's basically take-home point that the ACE/ARB, so ACE or ARB, by the way, it's not. There was a student in the past that thought maybe all three, but it's either pick an ACE inhibitor or an ARB, and then add that to a long-acting calcium channel blocker. So we're talking about two therapies, right? And then especially if they have their blood pressure is higher, or 20/10 millimeter of mercury above goal, that could be another reason. And benazepril plus amlodipine was the one they just studied. This is another question I have to give for students, but that it doesn't mean that's the only combination you can do. So it is any of those. Okay, I did a quick little edit. There's a kind of a typo here on this slide, but it's going to be fixed for the copy you guys get. But this is just basically saying that with the combination therapy, you do need to look at if the patient is obese or not. So if it's non-obese patient who's on an ACE/ARB plus thiazide and they are well controlled, that you don't necessarily need to continue that. They actually suggest stopping the thiazide and switching to the calcium channel blocker. But then if they are obese, then you can do a combination, the ACE/ARB plus thiazide. And that can be continued, and you don't have to worry about adding them or switching them to the calcium channel blocker. So that's, again, depending on the weight of the patient. And then also for the obese patient, it is suggested to go to continue them if they are well controlled on a combination that's other than an ACE or an ARB plus a thiazide. So this is just saying if you come to a patient, they're well controlled, don't think that just because they're obese, then you have to discontinue whatever they're on and then put them on the ACE plus the ARB. So hopefully that's clear. This is just something that, because you do come across patients that are on combinations that the guidelines don't recommend. But if they're well controlled, they're not having adverse effects, they're not having any problems with it, don't think that you don't have to go back and, and again, if there's no contraindications or if they don't become pregnant or whatever, again, specifics of the patient are going to obviously determine what you're prescribing, but don't think that you didn't have to go back and kind of wipe the slate clean and start them all fresh on drugs if they're on something that's controlling their hypertension, and again, no contraindications, no bad adverse effects, they can afford the medication, they have access to the medication, etc. So this is interesting too. So the guidelines recommend that, so if there is a patient being treated with a thiazide diuretic, and they have not attained their goals, right, so it's ineffective for them, there is a recommendation to then go ahead and discontinue that completely and then just go ahead and start them on an ACE or an ARB plus a calcium channel blocker. And again, because of that ACCOMPLISH trial, there's just been a lot of evidence and a lot of positive results from that combination. And they're actually superior to maybe the thiazides plus ACEs and ARBs. So Another just interesting note about dosing, that as long as it's not a diuretic, so diuretics usually make you go to the bathroom, right, as one of your side effects. It causes diuresis, so it causes fluid loss. So they don't recommend taking diuretics at bedtime because the idea is you have to wake up, then to go to the bathroom, and maybe because you're on an antihypertensive, you have low blood pressure or you has dizziness, etc. So that's something that they don't recommend doing. But then with other antihypertensives, so like your ACE inhibitors or your calcium channel blockers, they recommend taking one at bedtime. And the reason is, you can read the rationale here, I put it here, is because when you sleep, a healthy individual, your blood pressure should dip down. And so if it doesn't, it's called non-dipping. And so the idea is that these pharmaceutical agents will help you have that dip in blood pressure, because a person with high blood pressure, maybe is not having that benefit of having their blood pressure go down at bedtime. So anyways, and please read through the rationale as far as the benefits of that. And that is my last slide. So hopefully this was helpful, beneficial. I know it can be, students have complained in the past, this is kind of confusing. Some of these slides seem to kind of contradict themselves. And it sort of seems like with, going in opposite directions, etc. Just please, that's why I started with it. Just please, take the perspective that you really need to look at that specific patient. Are they obese? Are they not? Are they old or not? Are they going to be pregnant or are they not going to be pregnant, right? And then that's going to really guide this is just some framework. It's based on the guidelines, JNC 8 and the European one. So hopefully this is beneficial and helpful, and hopefully it helps and kind of mirrors what you guys are learning in ICM. But as always, please feel free to email me specific questions or any concerns, whatever you guys have. And also thank you guys for your time and attention. I always appreciate that. I hope you guys have a good one. Talk to you later. Bye.